Assalamu alaikum. Good evening to one and all who have joined us here. Let me introduce myself in the beginning. So I am Dr. Nidha Begum. I did my BDS from KVG Dental College, Sulia, and I did my master's from AJ Institute of Dental Sciences in Periodontics and Implantology. So today I'm hosting the webinar on India's preparedness with dental health care facilities by Dr. Sabah. So now I'm pleased to introduce Dr. Sabah to everyone. She's completed her BDS from KVG Dental College, Sulia, after which she's worked in MA Rangunwala Dental College as a faculty in Pune. Then she pursued her master's in public health from Manipal University. After which she worked as a research assistant in KMC Mangalore for the Bill and Melinda Gates funded Rotacil vaccine trial project. Presently, she is doing an amazing job as a district program coordinator for Dakshin Kannada. She organizes training programs, orientation workshops for medical officers and community healthcare officers. So without further ado, let's begin the talk. Dr. Sabah, over to you.
Thank you so much, Dr. Nidha, for the wonderful introduction. I'll be sharing my slides. Good evening to everyone.
Yes.
Do let me know if the slides are visible. Yeah. So we are actually going to have a sneak peek into the topic where how India is prepared with the dental care services from the rural to the urban places, areas of the country. So the learning objectives, yeah. So in this session, by the end of the session, I feel everyone will be knowing the oral healthcare services at each levels of the healthcare system in the country. That is from the sub-center level to the district level. And also the key task of the medical officer at the primary healthcare center, because there is an absence of a dental dentist at the PHC. So how medical officer is taking care of the oral health care of the population. And then of course the in-depth referral pathway for the oral health related conditions. Yeah. So Ayushman Bharat Health and Wellness Centers. This is a excellent and the huge program which is started under the Ministry of Health and Family Welfare by our Honorable Prime Minister Narendra Modi. The idea behind this program. Hello.
Yeah, we can hear you.
Yes. It is an attempt to change from the sectoral and the segmental approach of the healthcare delivery system to a more comprehensive form, where the health for all will be ensured. Universal health coverage will be given at a village level. So CPHC, if you see there, it is the program where 12 healthcare services will be delivered at the sub-center level. I'll be explaining in details in the next slide. These are the 12 healthcare services delivered at HWCs. HWC is Health and Wellness Center. So the whole new project is like converting the primary healthcare center to a health and wellness centers. So what is good thing about it is the more comprehensive form of healthcare delivery will be done here. So if you see the star mark, oral healthcare is also included now in these package services, where when you think about that, oral healthcare is always ignored, which can be now said that it is not ignored anymore. And we will be also seeing how the oral healthcare services will be implemented in the village level. So the delivery of the oral healthcare, quality of the oral care services is envisioned as a joint team effort. Of course, the health is a joint team effort where you have ASHA workers. ASHAs are the community workers, and CHOs, community health officers, and MPW. MPWs are the multi-purpose workers who are working at the sub-center level. Then medical officer at PHC and dentist at the secondary level. Yeah, dentists are not present at the sub-center level or primary healthcare centers. Okay, so we have in-depth discussion on that as well in the coming slides. So if you see this pyramid, the base of the pyramid, ASHA workers are like soldiers of the, the entire healthcare system. They are actually doing a tedious task of, implementing all the program, National Health Mission programs. So each ASHA are divided by 5 to 100,000 population. So she takes care, she has the detailed information of in every household, how many members are staying and what are their health needs. So she maintains her register, what individual has what, at which attention needs to be given to the particular individual. ANMs are now in Karnataka, if you see, ANMs are called as PHCOs, that those are primary healthcare officers who are also associated with the sub-center. So the main, the role of ANMs are to give a field visit and screen for the communicable and non-communicable diseases, identify the patient, and then mobilize the patient to the nearest health and wellness center. Then we have primary healthcare center. Here, a medical officer along with his team will be working, and usually the primary healthcare center caters services to 3,000 to 30,000 of the population. Then we have community healthcare center. Under community healthcare center, we have 5 to 6 PHCs working, and CHC will be catering to around 1 lakh of population. Then we have district hospital, which is catering to the entire population of the district. Levels of the primary of the prevention disease, I would explain like at what level what activity has been taken off. Health promotion and health education, this activity where you need to promote the schemes available by the government or the awareness activities sort of things, happens at the sub-center at the community level. Who will be doing this? ASHA workers. Of course, with the supervision of the medical officer, ASHA workers will be doing ANMs and CHOs. Now, CHOs, our district was running with ASHA workers and ANMs, but now there is maybe around a year ago, there is introduction of CHOs. Now, CHOs are community health officers. Karnataka state government has decided to enroll BSc nursing candidate for this particular post. But if you see other states of India, they are enrolling dentists for this post, or Ayurvedic doctors, or homeopathy doctors, or any other traditional medicine degree holders. So, of course, if you are hiring a doctor for this post, the pay scale also varies accordingly, and also the incentive scale is different from the what Karnataka is providing for the CHOs. Then is screening and early diagnosis. Now, screening of the disease happens at the sub-center level as well as PHC. So once the CHO or the PHCOs identify the patient and screens, the patient is then referred to the PHC, where the medical officer will give the confirmed diagnosis. And disability limitation and rehabilitation, this phase, when the patient is already into this phase, then patient will be referred to CHC or the district hospital, which is loaded with more advanced technology, and more of diagnostic services are available at CHC and district hospitals. Now, oral healthcare services delivered at different levels, we'll see. So we have community visits and community platforms. So what is VHNDS and VHNC? So these are the village health nutrition days, which are, decided by the medical officer, and sanitary day meetings. All these kind of government meetings will be decided in a week. Every week it is organized. There, this oral health education is given by the ASHA. Okay, so now the question arises, like, how ASHA worker will be giving the awareness regarding the oral health. So again, government provides the funds every year to train the healthcare workers, and they will be doing this awareness activities and health promotion activities at the field level. So oral hygiene practices and myths and taboos and everything will be cleared. And also along with the tell and show do technique, then they have IEC banners and pamphlets and everything will be provided by the government to explain it to the population. And what do you say, to identify the case. Also, they will be identifying the case, and then necessary wherever the patient needs to be referred, either CHC, PHC or district hospital, will be decided by the ASHA. So usually ASHA worker, once she identifies the patient, she will refer it directly to the subcenter or to the nearest PHC, which is always located at the nearest in every wards or the village, if we divide. Then we have screening and early detection. So what is CBAC form here? As I told, screening for the communicable and non-communicable diseases will be happening at for the 30+ population. So it is the CBAC form as the checklist, community-based assessment checklist, where they have a set of questions which will decide on the risk factor of the particular individual related to specific diseases. Then you'll be thinking like 0 to 18 years of age group will be ignored. No, this population is also taken care under the program RBSK, which is Rashtriya Bal Swasthya Karyakram, where the children, this program is of course coordinated with the Anganwadis and school program and government school program as well as private school program. So whatever what do you say, objectives are there under this program is been taken care by the medical officer of that particular area. Then early detection of common conditions. Yes, the identifying the case. So the funds given for the training of this ASHA workers are alhamdulillah very much adequate, because there is also, we can also reorient them after every 6 months to 8 months regarding the cases, so that they do not miss out any individual which are actually suffering for particular diseases. Then facilitating referral and follow-up care happens at the tertiary level, where the treatment adherence and follow-up care will be done at every level, at PHC level as well as subcenter level. Treatment adherence is also checked by the ANMs, giving house-to-house visit or by conducting outreach activities. So every month, every subcenter has an quota of conducting at least two camps, outreach camps, for the population of their respective subcenter. So there they will actually follow back with the patient and check whether the patient is seriously adhering to the treatment. Yes, as I said, community-based checklist, assessment checklist, it is a CBAC form. I have highlighted these questions because these questions are related to the oral healthcare, where the ASHA worker just has to mark yes or no. And then the whole checklist is in the form of software. There is a software given by the state, by the government, NCD app, where they need to just mark yes or no, and then there is a marking system where it gives a number. So if the number is 4 or more than 4, it is like the patient is at risk and needs to be referred to the nearest PHC. So difficulty in opening mouth, any ulcers in the mouth that has not healed in 2 weeks, any growth in mouth that has not healed in 2 weeks, any white or red lesions, patches, pain while chewing. These kind of questions will actually indicate whether a patient is having submucous fibrosis or leukoplegia or any precancerous lesions. So yes, now yeah, I'll be explaining about what measures are taken at the PHC level. At the subcenter, so what happens at subcenter? The CHO will also give a house-to-house visit, but at when a patient comes with a particular complaint, at the first level, what the CHO will do is try to give the antibiotics or the painkiller at that moment, and then if it is bleeding, he'll try to arrest the bleeding there and then refer the patient quickly to the medical officer, that is at PHC. Also, when they have to arrange a dental camp at the subcenter level, they will also collaborate with other program officers, that is NPCDCS and NPPC palliative care, that is National Palliative Care Program, also the non-communicable disease program, so that when there is a when there is a collaborative work happening, so the patient gets the attention quicker. So the patient can be mobilized to the nearest either Taluk hospital for the biopsy in case of oral cancer, or for the treatment to the district hospital. At PHC, what happens is, as I said in the CPHC HWC program, the training is not only given to the ASHA workers, but also the training is given to the medical officers pertaining to the oral healthcare services. So here, all the medical officers will be trained to how to identify the case, and what if the patient, if they have a child coming out with a fall and the Evel's tooth, what is the first line of treatment, and also fluoridated programs to be conducted in the school, and identifying the oral cancer lesions, precancerous lesions, and referring the patient to the Taluk hospital. So Taluk hospital and district hospital will be having also has a service of biopsy, and diagnosis has been done in Taluk hospital as well as district hospital. For the more complicated cases, there is also an MOU signed with the private medical dental colleges, where the patient can be either the PG students do visit the district hospital to treat the patient, or the patient is transferred to the private dental hospital. Yes, so if you see the documentation, these are the list of dental procedures to be done at PHC level, but only if dentist is available. So at PHC, we do not have dentist. We have dentist at in CHCs, Taluk hospitals, and district hospitals. So what are the drawbacks? What are the procedures which should be done but it is not done? Are the list, like restorations, scaling, deep fissure sealants, or the basic access opening. All these kind of procedures can be done. We can now here you can pitch in by putting up a proposal that we can have a opening for a dentist for the as a rural service, after how you have medical officers, I mean MBBS students completing their degree, and they do the rural service. So we can have this dentist's post can be opened up, and we can also render the actual dental procedures at PHC level as well. So role of a medical officer at PHC. Now, as I said, there is no dentist, but the medical officer has been given a 2-day training. Each medical officer in the district, a 2-day training has been done, given by a specialist for specifically for this dental services. But now I would like to ask a scenario. I'll ask the question, like, this is a scenario where a lady comes to the PHC with a 10-year-old son, saying that he has been complaining of tooth pain and not eating anything for a week. There is no dentist post at the PHC, right? Describe the role of the PHC medical officer in the management of this case and related functions. So what will be the step taken by the medical officer? Can we have any answers from the audience?
Ideally speaking, I think the attending medical officer should be in a position to refer the mother and the child to an appropriate center where they have the dental facility. If that's possible, the least he can do is prescribe a medication to ease the pain, and also to direct the patient as to where exactly he can go to get the treatment done.
Yeah, yeah, that's right. But as the medical officer is now trained, he should actually be looking into the oral cavity, like why there is a pain, for what reason. Is there a food lodgement which can be easily removed at PHC, or is there, as the child is 10-year-old, so maybe the tooth is mobile and going to be shed off in next few days, so which can be handled at his own clinic before just a dental case comes, and he instead of just referring it to the CHC where the actually dental posts are there, but he can handle, if the case can be handled at its own center, primary healthcare center, right? So maybe being a 10-year-old child, maybe the child is just complaining, it's a pseudo complaint, like it's not there, but then it's just there in his mind, maybe that sort of thing. So who is responsible for providing that service? Yes, of course, medical officer. Okay. And if there is pulpotomy involved or something, where actually the patient needs to sit in the dental chair, then the patient can be referred to the CHC. Or if at all there is a lesion involved, like which actually requires a specialist to view, then he can directly refer the patient to the district hospital or the taluk hospital. Okay. And yeah, here I would like to have some answers from the audience. Identifying, see, these are the services, I'll be reading it out, and the level of care, in which level of care it fits, and who is the provider. So identifying the symptoms of common oral diseases using CBAC form. So whose duty is it to fill the CBAC form, identifying the patient from the field visit?
Asha workers.
Exactly.
Or the
ANMs, Asha workers, ANMs. So they are the providers. They have to fill the CBAC form and categorize the patient into the high risk, low risk, or the patient is just requires the counseling to be done. So next is, and that is the sub-center level of care. Okay. Planning and organizing oral healthcare awareness camps. Who does that?
I think these are the PHCs.
Medical officer as well as CHO. So it comes under which level of care? Primary as well as sub-center level of care. Okay. Supportive supervision of the CHO and SHC. HSC team is again sub-center team, sub-center HWC team. So who is supervising their activities?
I think the taluk level.
Medical officer. No.
Medical
officer of PHC. Yes. So see, PHC is catering to almost 30,000 of the population, correct? So
okay.
Under this PHC, there might be around 5 SCs or 3 SCs as per the population. So sometimes some PHC just has 6,000 population. So there we just have 2 sub-centers.
Interrupt, Dr. Sabah. You mean to hint that we do not have a dental officer at the primary healthcare center? That's what you're hinting at?
Yes, we do not have.
Are you serious about We seriously do not have a dental officer at the primary healthcare
No.
center.
No. We just
Preliminary
have
diagnosis.
at
Okay. Dental
CHC,
dentist.
taluk hospitals and district hospitals. So primary, and usually what is happening at primary and sub-center level, it is
Okay, that's what you have
awareness
been
activities,
in past two
IC
slides.
activities, and yeah, tell me, go on.
Yeah, that is what you were hinting at, that we lack a primary,
Correct. Yes.
dental officer at the primary healthcare
Yes.
center. That's what you're hinting at from past 2-3 slides, isn't it?
Exactly. So unemployment here can be, solved by actually putting up a paper for the young budding dentists who are just pass out, and they can actually be allotted on these PHCs. We have around in Karnataka, Dakshin Kannada district as itself, we have around say 75 PHCs. So if we have dentist BDS openings in these PHCs, we can actually render basic dental services to the population.
So the request
Yeah,
is
you're
to go with
suggesting
the dental
we
council
write
of-
to the government to open up the vacancies in such centers,
Yeah,
or
IDA team, yes, Indian Dental Association can always put a pressure on this factor. They can actually, make use of, see, when there is already a government has put up this Ayushman Bharat scheme here, you can always put an extra effort by getting out the need assessment.
Exactly. Yes. But how do we do that, Dr. Sabah? You have to guide us on this.
Yeah, I'll be sharing few contact details. You all may directly talk to the concerned person. All right.
Yes. Just go ahead.
Yeah. Then we have coordinate with RBSK. RBSK is Rashtriya Bal Swastha Karyakram. That is again a program, run by the government, and school health program to ensure oral health checkup for all children. So who does this? This
Mobile
is
health teams.
organized by the medical officer. Yes, this is organized by the medical officer in collaboration with NOHP. NOHP is National Oral Health Program, and there is a nodal officer working under this program. Then there is lab technician and much more people in this program. So along with this team, NOHP team, they organize for this school dental health programs as well.
So NOHP team is not in sync with our IDA.
AB,
In-
Ayushman Bharat. Yes. See,
Okay.
National Health Mission has around
Ma'am,
44 programs.
NOHP is not linked with
In
ID.
collaboration. Yeah.
Collaboration with ID.
Now, this is this 12 service package. This program itself is covering all the programs which are running parallelly in the under National Health Mission. So whenever, for example, if they want to conduct a NCD camp, NCD is non-communicable disease camp, they will be contacting NPCDCS, District Program Coordinator, and then conducting this camp. If they want a malaria, only specific to malaria detection camp, then they will be contacting vector-borne disease program and then conducting the camp. I hope you all are understanding. So for every disease, there is program under IDSP. Now this is another program where you have communicable diseases surveillance happening under this. So the camps are conducted along with the
Oral health. It is National Oral Health Program.
yes. So every district has a nodal officer under this NOHP program.
This is
right?
independent, or this is not in collaboration with our state dental council
It is
or the.
It is a government programs, no? So it is the program objective is to conduct dental camps, render services. So here the PP model plays, for public-private partnership. So NOHP will decide on like where the dental camp has to be conducted, and then they will contact the nearest dental college where the students.
For PPP model MOU, doctor, if we could, are we going to get that in future slides? Any template of the MOU for the PPP?
I do not have that. No,
Okay.
this is AB. Yeah, I am just sticking to the Ayushman Bharat plan. Yeah.
Okay. But you can procure it for us in.
Yeah,
if
sure.
needed.
Yes. So
Okay, no.
Yeah, MOU has been signed between many dental colleges here because Dakshin Kannada is populated with the medical as well as dental colleges. So we have when we have a specialized case where a specialist is required.
Private, this one collaboration, you're only talking about the dental colleges. You've not gone to the dental clinics or dental hospitals as yet.
No, dental clinics are not collaborative. It's
Okay.
just dental colleges and district hospital like NOHP program.
Okay, fine, noted.
Yeah. Then we have which service promote oral hygiene through VHNDs, Village Health Nutrition Days. So in Village Health Nutrition Days, it has to be conducted every week. One day is decided by the medical officer where the population, will be gathered. And those activities and the talks and focus group discussions regarding the tobacco cessation activity or any other factors of the health will be discussed with the village people. So who does that?
Community. Okay.
Yeah. ASHA workers and MPW is the multi-purpose workers. They can be either males or females. Management of dental or facial trauma tooth avulsion as per the clinical protocol is actually done at CHC and district hospital. Okay. By the dentist or OMF surgeon, but in case if we do not have surgeon in the hospital, then of course here comes the role of MOU, which is signed with the dental colleges, where the postgraduate students will be taking care of the case. Follow-up of referred patients to ensure compliance to the treatment will be done at
District.
No. Follow-up will not be done at district. Follow-up will not be done by CHC doctors. It will be only done at sub-center level or PHC. But usually the follow-up cases, whether the patient is adherence to the treatment, everything happens at the sub-center level, done by the ASHA worker, ANMs or CHOs, because they give field visits. They arrange for camps, frequent camps. So they will again screen the patient, whether the parameters, for example, of the NCDs have come down or not. Right. Conduct and coordinate oral healthcare trainings for various healthcare workers, school teachers, volunteers, etc. It will be done by the medical officer at PHC level and community level as well. But the level of the training will be different. Okay. Now, referral pathway, it is the same thing what I have been explaining to the previous slides, but I will just run through quickly. So community level, ASHA workers and MPWs are really trying hard, and they are working extremely in the sun, scorching sun and everything, and getting the information about their respective population in the registers, that who is suffering with what, and who has the dental problems, who has tooth pain, swelling and everything will be taken care, will be known by the ASHA workers. And 0 to 18 years is taken care by RBSK program. Completion of the CBAC forms, that is 30 plus, is done by the NPCDCS program. Early detection of conditions like pain and potential malignant lesions. So of course, yes, with the pictures and the videos and everything, the training every year happens by the district program coordinator, where the coordinator or the public or the program officer will be explaining the disease, how the disease looks, how the patient comes with the symptoms clinically, how it is visible, how it looks, and what is the alarming sign, where she has to directly send the patient not to the PHC but directly to the taluk hospital or the district hospital. Okay, then what happens once she goes to the house, she comes to know, okay, this is the patient which requires this attention. She will give it to either PHC or subcenter. Then from the PHC, if the patient goes to the subcenter, then the CHO will refer the patient to the PHC by giving the basic painkillers or the antibiotics or something like that. The first aid will be done at the subcenter, and then will refer the patient to the primary healthcare center for medical officer to confirm the disease. Then the follow-up, once the disease is confirmed, counseling is done at the PHC level. Counseling ke liye bhi, medical officers will be trained. Then the follow-up and the adherence is taken care by the subcenter. Or if further complicated case, if further tests or diagnosis or sonographies or any sort of like mammograms need to be done. So all those facilities are available at the Taluk hospital or district hospital. So the patient will be referred to the higher tier of the healthcare system. Then again, after the treatment is done at these tertiary care facilities, the follow-up and treatment adherence will be again taken care by the subcenter, at the subcenter level by the subcenter teams. Dantabhagya program, maybe all the dentists will be aware about. So this is an excellent scheme by the state of Karnataka. This scheme is not implemented in other districts. So Karnataka is an example, setting an example of how Karnataka is not neglecting the edentialism in the elderly patients. It was started in 2014. It is an excellent PPP model where the state government has collaborated with the dental colleges of all the dental colleges of the Karnataka, and where the service is given to the BPL patients, below poverty line patients. So either the removable partial dentures or complete dentures. So here ASHA worker is also trained to identify the patient from the field, refer the patient. If she is referring the patient to the nearest dental college, she gets an incentive of 100 rupees. So even she is motivated by that she is going to get incentive out of it. And the number of dental dentures being delivered, all that, what do you say, the funds will be provided by the state government. So eligibility criteria is 45 years and above, and it is only for the BPL patient. So I have also written a paper that this is an excellent scheme which should be grabbed by other states of the country, but it should also include APL patient population as well for the scheme. Yeah, we are done with the slides. Thank you for the attention. And can we have the questions, or we can, I'm open for the discussion. If you have.
Yeah, I have a question, Dr. Sabah.
Yes,
In the dental scheme, I think you said there are some incentives. You meant to say every partial denture or complete denture, the
yes.
dentist fabricates, the dentist gets 100 rupees?
No, not dentists. See, ASHA workers. Now, ASHA workers are, I'll tell you, they are not qualified, or, many of the ASHAs have not even completed their 10 standards. So,
no, but who gets to fabricate?
They are doing the hard work of mobilizing the patient, motivating the patient that they require denture, otherwise it will indirectly affect their systemic health. So all this needs ASHA worker is telling to the patient to get the patient out of the house and go and utilize the services from the government. So that 100 rupees they are earning, that is the incentive ASHA worker gets.
Okay.
Yes. So, and again, NOHP program will be giving the training for the ASHAs in the budget which they receive every year. So now when we get the budget, we actually have to spend it. We actually have to train. We are receiving budget for IEC. We are receiving budget for trainings, for other finance, for the other equipments and all that. We need to spend it. We need to show it by, spending it by making the primary healthcare center fully loaded with the essentials. And if you do not spend the budget on time, the next year the budget reduces because you are not spending. That means there are no beneficiaries. That means there is no need of the money to render services to the population. So we cannot show a lazy side by not utilizing it for the people. So that is how it is ensured that the beneficiaries are getting benefited. The beneficiaries are utilizing the services provided by the government. Now, government is doing a lot. If you see, there be it educated population, literate population, but dental or be it any other health related problems, it is always ignored until and unless you get the pain, until and unless it is stopping your daily activity. So here it is important that awareness activity, if it is ignored by just once in a blue moon conducting an awareness program or any camp, it is not going to work. It has to be a continuous activity. So the 12 service packages now include oral health care. Now there is, we cannot say that enough work is not happening at the ground level. That's why the people are not utilizing the services provided by the government. Yes, of course, implants and other aesthetic services are not available at the district level. You'll have to go and visit a private clinic, dental clinic for that. But the people are, health for all is an essential. The basic oral healthcare services free of cost is essential for a human, for a individual, for a citizen. So government has come up with these packages. And now the services, now the more the people are aware about it, then you will have the utilization rates going up. And yes, dentists are available only at CHC, Taluk Hospital and district hospitals.
But any idea as to how much of funds have been allocated for such schemes, as in Dantabhagya or other schemes, oral health welfare schemes?
To give the figures, I would, I'm not the right person because we have finance and logistic consultant and all for every program. So there is separate funds given for each activity, for IEC printing, for celebrating those World Cancer Days, World Oral Health Days, and all those. There is separate budget coming in. For example,
funds enforced by the total population of the taluka or district level, or how is it?
No, it comes to the program. So that, for example, there is I'll explain you about my this thing, NPCDCS program. For NPCDCS training each year, 2.5 lakhs comes. For palliative care, 1 lakh comes, and then for elderly care 1 lakh comes. So every year it is coming, this budget is coming. I will have to decide on how much I can train, how many human resources I can train in this budget. Okay, the next there is around for this Ayushman Bharat, there is now 64 lakhs which we need to spend, and the time maybe every year I need to train, because this is a huge program and it covers up all the diseases, all the programs. So now the budget.
The 64 lakh is per annum, or is it per program?
No, for this is the new program. So this is like 64 is given. So maybe we have around 2 years to complete it, 2 to 3 years to utilize this budget. So we
have a time frame to utilize the funds.
Yeah, we have the deadlines. So we have to divide like 64 lakhs a year. Now, how are we going to utilize it? So we will be buying necessary equipments, like for the elderly, wheelchair is required. We require maybe other calipers for the elderly patients. We require, if we see a stethoscope, we require glucometers. We require.
We do not have exclusive funds only for dental, like for oral health. We do not have a separate fund.
They do have to maintain the clinic at CHC and Taluk Hospital. There is separate funds.
Oral health for all. Are you including your mentally compromised? Because I did see.
No, medical. No. Mentally compromised. as such, exclusively for this category, we do not have a program running. Everything comes under, yeah.
Bharat is not including RCI, Rehabilitation Council of India. There is no coordination between RCI and Ayushman Bharat. The Rehabilitation Council of India is still
No.
remain. Okay.
No, it's not.
Okay. So those people are still deprived of these funds, which are allocated for Ayushman Bharat.
Yeah,
The
see,
RCI
see, these are the 12 packages, you know, these
Yeah,
are
I
the 12
understand that,
services.
but then there is no,
no,
yeah, I did see
no.
palliative, I did see oral health care. So that's why I wanted to ask, mental health ailments you've written, I think the 12th
Yeah.
point you've written. So you have, there is no effort of Rehabilitation Council of India getting involved with Ayushman
No,
Bharat.
specifically, no.
Okay. Okay. Yes.
Yeah. Mhm.
Probably there's lack of awareness of RCI statutory board in regards to the Ayushman Bharat, or there is a deliberate segregation. I'm not sure. We'll have
No,
to
there
look
is no deliberate segregation, but maybe RCI is collaborated with mental health care, or is it collaborated? Is it, you know, coming under any other program?
No, it doesn't come. It's as a single independent statutory like the Dental Council of India. We have Rehabilitation Council.
No, ma'am, it is not. It is not. It is not associated with this
But
program.
is there any scope of Ayushman Bharat, including RCI? Is there any pathway for it?
If we need to conduct any sort of awareness program and all, it is open to all. Like, we do collaborate with other programs, and then we conduct the awareness activity or the screening activity or anything of that sort. But
What I understand is when you compare our country with the maybe any other country abroad. So there is a conscious effort of rehabilitation procedures, rehabilitation protocols, or the population who requires rehabilitation.
rehabilitation centers are there at district level, so those
Yeah.
services are there. Yeah.
Rehabilitation for mental health.
That is also taken care. Yes, mental health, there is a separate program running, mental health program. There is telemedicine. Yeah. Now, one more thing is, under this Ayushman Bharat, there is telemedicine also, which is given, you know, a lot of attention, and there is another separate section for dental team as well. So that is another way of having a vacancy for dentists in telemedicine. So even
the purpose of telemedicine was, as what I understand,
e-Sanjeevani by the government.
Yeah. I'm a part of the project here in Saudi Arabia, tele-dentistry.
Okay.
The purpose of dentistry and telemedicine is basically to declutter the waiting list in the primary health centers. You have a lot of waiting lists wherein the patients are not able to avail the medical.
Yeah, the technical glitches there, sir, here also in India as well. The technical glitches there. There is a lot of waiting, this thing, numbers, 100 around. Maybe you need to wait for another 30 to 40 minutes to get your number. But then I feel it is still, it is a good initiative.
This waiting list is what the telemedicine and teledentistry does.
Mm-hmm.
You are asking something, sir? You're asking us something?
I'm so sorry. Actually, I've lost my voice because of infection.
Yeah.
No, I didn't understand, sir, your last statement. Like, are you?
Yeah, the purpose of telemedicine and teledentistry is basically to ease and identify the definitive reasons for seeking treatment. Now, for example, if a patient is having pain and he's just waiting, is going on to seek a medical attention, and then suddenly he is put on a waiting list, he is not a priority to seek medical attention. He can just be handled on telemedicine, and then he can be prescribed medicines, and he can be, assessed as to what exactly is his emergency and urgency.
I hear you're telling me that the patient is put on the waiting list. Is the waiting list you meant is like to get the appointment with the doctor, that waiting list you're talking about, or for the treatment waiting list?
For the treatment waiting list.
Okay. No. I'm not
What
Because I'm not
exactly
working
happens
for the
in telemedicine
telemedicine,
in
I
India
am
now?
unable to, I'm not working for the e-Sanjeevani part. That's why I'm unable to answer your this
I think what
question.
he's trying to
But
convey is, like, the patient is trying to connect to the doctor because of the emergency. But then the connection itself is stalled for so long. So the emergency is not addressed immediately. I think that is what he's trying to convey.
yeah, there is always advantage and disadvantage. The patient is using telemedicine because he is unable to
Yeah.
access the center.
Yes.
So somewhere something has to be compromised. Either the internet issues will be there, or there is actually a long waiting list. When I had actually used the telemedicine option through my phone, my waiting list was 114, and I had to wait for around 30 minutes. But then I was well satisfied after when I got the appointment with my doctor, and I got the e-prescription within a seconds after my consultation. So
I think
I would not say this is, there, if there is one or two disadvantage, there is a lot of advantages, because patient sitting at their own house or at their comfort zone, they are able to connect to the doctor.
Yes.
Yeah, with the e-prescription, that is also more important, because slowly we can also, avoid the, what do you say, those drugs which are easily just available without any prescription from the medical shops.
One more thing I want to ask Dr. Sabah.
Yeah.
All these schemes which you just mentioned now, they come under the ambit of the National Dental Commission Bill or the previous existing Dentist Act?
No, 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 no. I don't think so. Doesn't come under that.
It comes under what?
This is a program running. It is not. This is
It's a parallel
individual.
schemes run by the government, is it?
Huh?
Yes.
They are the parallel schemes run by the government. They're not under the
Yeah.
National Dental.
No, 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 no. It's parallel. Yeah. They have their own budget. They have their own human resources, and that is running separate. This is another. This is a separate program which is running. So if they're, for example, if they plan out to conduct any sort of dental activity, camps or anything, they can obviously take the human resources of this program and then conduct. So there will be many people involved to
My
conduct one.
concern is, I mean, is the dental regulatory body involved in such schemes, or is just the schemes governed by the government itself?
These are the schemes by the government. These are the facilities provided by the government hospitals.
But there's nothing to do with the dental regulating bodies.
No, 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 no.
Okay.
So that is what Dr. Sabah is trying to convey. Like, if the regulatory bodies come in to pitch in and create some vacancies at the PHCs, then
Yeah.
the dental employment can increase. So, I think it's delegating the jobs. Basically, I think we've left the government to run their own programs and the statutory boards to run their own programs. So
Yes.
collaboration would do wonders, but of course there is lacunae.
Yes. So when there is the 9th basic oral healthcare included in the services, you can always have a paper out by the Indian Dental Association or any other, associations are there, dentist association. They can put up a proposal of making providing a services, providing a vacancy or a post at PHC level. So the young dentists who are just passing out from the dental college, they can actually give the basic treatment there at primary healthcare center.
We'll work for it, provided you guide us how to go about it. Probably,
Sure.
we could pitch in and try to create some vacancies for the fresh graduates and the general
Yes.
practitioners. I think the general practitioners can be well taken and apt for the primary healthcare centers, especially the rural dentists.
Sure, sure. Yes, ma'am.
And like I spoke initially also about the special needs children, wherein the public itself is not aware that they can also prevail or avail the dental facilities. So most of the rehabilitation centers should be made aware where they can't afford. Of course, even the private dentist is maximum times avoiding these children. So as well, they can procure some from the government and address their own. So we'll work on it, provided you guide us. It was a
Yes,
nice,
sure.
heating up discussion. I guess it never stops once we get into it. So any more questions, Dr. Nidha?
No, ma'am. It was a very informative lecture, Dr. Sabah. Thanks a lot. It was a very, I think we have takeaway points from your talk. So let's see what we can do about it.
Yeah, even I'm glad that Dr. Guzia ma'am has given me opportunity to speak on this platform, and it was an excellent experience for me. Thank you so much for being keen listeners.
Yes.
Thank you, Dr. Nair, as well for the doubts. Those were actually, yeah, quite, eye openers, those doubts. We must work in that direction as well to get, to ensure more of, 100% of implementation.
Yes. Ma'am will leave
Will
the
wind up.
Will wind up.
I think we have Dr. Mushraf Anisa thanking us. So,
Yes.
well, thank you. It was a great talk.
Thank you so much.
Thank you. Let's please. Okay.
Okay.